It is my honor to introduce our moderator for this session, Dr. Christina Davidson. Dr. Davidson is a maternal fetal medicine specialist and joined Baylor College of Medicine in 2007. She currently works at Taub Hospital and Texas Children's Pavilion for Women in Houston. Dr. Davidson works tirelessly for the health and safety of mothers and babies, serving as the Vice Chair of Quality and Patient Safety for the OBGYN Department at Baylor College of Medicine and the Chief Quality Officer for Obstetrics and Gynecology at Texas Children's Hospital. We are so fortunate to have Dr. Davidson as part of the Texas Collaborative for Healthy Mothers and Babies, where she has served as co-chair of the Obstetrics Subcommittee since its inception. Couple fun facts about Dr. Davidson. She loves moms and babies. I think that's evident. Not only is she a busy practicing clinician, she also has 3 beautiful children of her own. I didn't know this, but Dr. Davidson is actually a chemical engineer by training. So we know there's a reason why she loves data and numbers, and that is why. The other thing I've learned about Dr. Davidson, she's very efficient. She's constantly trying to find the shortest and fastest route from Houston to Austin, so I love it. So I'm going to turn it over now to Dr. Davidson to introduce our 3 distinguished panelists. Dr. Davidson.
Thank you very much, Divya. And funny note on the chemical engineering, I always wanted to be a physician, but my mom wanted me to have a good backup plan. So, but mama knows best. And I actually did work for a year at Procter & Gamble before going to med school. So I have the honor of moderating this next session, which is our first breakout session. And it is the OB panel discussion on experiences with maternal safety bundles in the OB setting. I think I will introduce the speakers since they're all going to speak separately. I'll introduce them as they come up. So our first speaker is going to be Dr. Carrie Eppes, who's going to talk on maternal early warning systems. And I could read from this, and I will a little bit, but I know Carrie very well. So Carrie is an MFM physician at Baylor College of Medicine, as you know. And as you just heard, I was the chief of OB at Taub Hospital for 5 years. Right after I left to take on the new position I'm in with quality and safety, Carrie became the chief of OB, but we have worked together since she came to Baylor back in 2012. And kind of funny story, when I was chief of OB and she was sitting in my office one day, she was like, just so you know, I have an interest in quality and safety if you need any help with anything. And I would say the rest is history. She was our quality and safety director for OB and started implementing maternal early warning system and AIM bundles years ago. And is here to speak to that today. I'm so fortunate to be able to come to work, go to work every day and get to work with her. And even though I'm at a different hospital now as well, I still tap into her brain on a daily basis. We talk daily. She's a very dear friend of mine. And I'm honored to have the opportunity to introduce her. A little bit more about her. She is the chief of OB at Taub and the co-director of the Taub High Risk OB Infectious Disease Clinic. She is also the Texas AIM faculty chair, so everything that's happening with AIM right now in our state, she is chairing that. She is our ACOG District 11 Patient Safety and Quality Improvement Chair, and she is, again, a co-chair of the OB subcommittee for the TCHMB. So I'm going to let her come up and speak on maternal early warning systems, and then I'll introduce the others as they speak.
A new rule, let your best friend introduce you for everything. Okay, hello. So our panel is talking about different OB bundles. Many of the people in the room have heard via AIM and TCHMB us talk about maternal early warning systems. So I want to try very hard not to duplicate things that you all have already heard, briefly make sure that we're on the same kind of playing field, but then talk about why we think this is such an important bundle and how it might take us into the next initiatives that we're doing and help across a couple of different OB/QI initiatives. So briefly, we'll review maternal early warning systems. I think this morning, Dr. Main kind of set the stage for why they're important, and I'll show some of the slides he's already shown again, and then how they'll help. So what is a maternal early warning system? I think most people have already heard in a couple of different formats. It's a system of escalation based on maternal vital signs. It's developed so that we react to those vital signs. We know for pregnant women, they tend to be a little bit different than the rest of the population, so you can't just use your hospital internal medicine vital signs and have them necessarily mean the same thing in pregnant women. For example, if you've got a 70-year-old male who's got a blood pressure of 160, that's going to mean a very different thing than if you've got a pregnant woman with a systolic blood pressure of 160. But getting people to realize when those early warning vital signs occur and have a timely response that is specific to those so that they're improved upon quickly. These are two different systems. I'm going to admit that my experience from my own hospital is the one on the left, which is the recommended version from the Council for Patient Safety. The one on the right is also a very good system, and this is from Larry Shields and Dignity Health, and something that they've used at a couple of the California hospitals, and I'll talk a little bit about the two, but the common thread is abnormal vital signs leading to a specific response that leads to earlier improvement in whatever that condition is. Why is that really important? So just as Dr. Bain said this morning, from reviews in California, if you look at what were the preventable portions of those maternal deaths, the number one cause was delayed response to clinical warning signs. At our AIM kickoff in June, we talked about a patient story from my own hospital where we had delayed vital sign recognition that led to significant morbidity. That is the exact reason why we started using that process, because that was unfortunately something that we knew was probably preventable. And it has been very impactful in changing the hospitals that it has been initiated in. So why is that important for us here in Texas specifically? If you look at a lot of the tools within AIM, there are a lot of big initiatives, but why have we carved out this maternal early warning sign piece of it? In just stealing shamelessly from something that even Dr. Bain said this morning, this portion of postpartum hemorrhage is sort of like the really significant reaction, or the on steroids reaction to postpartum hemorrhage. In other words, for postpartum hemorrhage, if you're enacting the maternal early warning system, they have probably already had a postpartum hemorrhage and showing signs of it. For many of the other conditions, it leads to kind of earlier recognition and response. If you look at what's going on for our pregnant women in Texas, which is why we are all here in this room together, these are the causes of death during pregnancy or 7 days postpartum. So for those of us in hospitals, that's something that we feel like we can catch a piece of. It doesn't mean it's the only area we need to work on, but a lot of them are things that can be changed by maternal early warning systems. So related to postpartum hemorrhage, NDIC, hypertension, sepsis, and things like that. Looking at morbidity, because we know for every death there are a huge number of cases of morbidity. It's similarly things that lead to abnormal vital signs that we can respond to and hopefully make a difference in. As we're going down our AIM journey, we know that many of the bundles, the one that we're currently working on is postpartum hemorrhage. I think predicted in the future is when we might start the hypertension bundle, but those maternal early warning systems are really the backbone of both readiness and recognition in both of those bundles. And I'm going to give a little bit of an example of how this looked at my own hospital. If you're looking at Larry Shields' MUTE algorithm, it starts with the abnormal vital signs, but after that, people are put into sort of various potential buckets as far as what the etiologies might be. And if you look, the one on the right is sepsis. We know that's a major problem. In fact, when my hospital got ready to start analyzing its own severe maternal morbidity data, we realized that's kind of what is coming out from our hospital. It's what we had to pull for maternal levels of care surveying, and we realized we needed to take some time validating our own data within our hospital. Once we excluded the transfusion, our biggest cause of severe morbidity in our hospital was actually sepsis. And what a confusing thing for OB. The next bucket is cardiopulmonary, hypertension, and then postpartum hemorrhage. And so it flows nicely into each one of these. So while we're using it to set up and make our postpartum hemorrhage AIM bundle more impactful, I think this is going to take us down the journey for the rest of our other bundles. This is just my hospital's outcome as an idea of what might happen. So we saw a significant improvement. This is before we did our postpartum hemorrhage bundle, 2 years before. So we did our maternal early warning system in 2017 and already started to have an impact on improvement in vital signs, but also in things like transfusion greater than 4 units without even having started the bundle. As I was preparing data for hypertension, looking back before we even started that bundle, I looked at our rates of giving magnesium for those with a diagnosis of preeclampsia with severe features, or for our timely treatment of hypertension before we even started the bundle. Just from having done our maternal early warning system, we were already meeting those goals the majority of the time. So our bundle got to just kind of come into place and help strengthen it going forward. So I think this really helps with the backbone for all of these other initiatives. Okay, disclaimer, this is just my internal hospital sepsis approach. I don't know how many of you have struggled with coming up with a diagnostic algorithm for sepsis. In our maternal levels of care recommendations, it says we should have guidelines or protocols for sepsis. What a challenge in OB populations when we know things like SIRS and SOFA or the other non-pregnancy related scoring systems don't really apply. And so we also realized if we went through it, obstetricians are really poor about doing things like checking a lactate or giving 30 cc's per kilogram of IV fluid or expanding antibiotics or doing those things that are really important for sepsis-related mortality. So we wanted to tie in what we knew was kind of one of our main quality and safety infrastructures, which was our maternal early warning system, and we knew was working into a way that people would then plug into the rest of our sepsis. I know California, I think, is in the process of working on a bigger sepsis bundle. And if you look at what the Larry Shields mute algorithm does, once you're in a category that might be infection in that maternal early warning system, then it starts immediately plugging you into the next thing. So I use this as an example, not to say that this is what everybody should be doing or that it's kind of our PQC example, but saying this is how we might use this maternal early warning system that we're starting to explore and do as our state project to then help with each initial bundle as we go forward, and whatever we decide is what we need to do for Texas. I was going to say in this algorithm, we then go to the sepsis and obstetric score. And so for anybody who wasn't familiar with that, this is a publication from a lady named Brenna Hughes, who's a big ID. This is how I tie in my ID and my quality and safety. Very hard to tie them in together, but in this instance. So this is a validated scoring system for OB for sepsis, and so that's why we tied our maternal early warning system into it. Again, this is just as an example of kind of the things that we can do as we move forward with our maternal early warning system. Thank you.
So next, Dr. Ann Borders is going to speak again, and she's going to talk about the hypertension experience in Illinois. And I think at this point she doesn't need to be introduced again, but I did get a little story over lunch that that I think is really very fascinating and another testament to what amazing work she's doing and will continue through generations to come. Dr. Borders has 3 amazing children who sound to be very active children and keep her in emergency rooms quite often because they break some bones. But during a recent experience with being in the emergency room with one of her daughters while they were waiting for a very long time, they both witnessed some interactions with the kind of the front desk staff and some patients who were treated unfairly and with lack of respect, possibly due to race and ethnicity. And so it sparked a conversation. So Dr. Borders rightfully stood up and said something about it and was a patient advocate for them. And the daughter got to witness this and recognized herself what those differences were, and then proceeded to tell Dr. Borders that she should apply for an NIH grant so that she could plant people in different emergency departments around the place to kind of watch and observe and see the different healthcare inequities and what we can do about them. So thank you to Dr. Borders for everything she is already doing and for raising the next generation of quality and safety specialists.
Thank you, Christina. If they don't kill me first, we'll see if 6 broken bones so far and counting with 3 children. It's a little excessive. I'm going to start getting investigated. I have rambunctious children. So let me use my time wisely. Let's see. Wait, can we pull up?
No, go the other way.
Can you, there we go. I think they're doing it magically back there.
I know that they are loaded. I have seen them.
Can you guys pull up for borders? Is it there? Or she says, give me a minute. Okay, well, we'll take a minute. How many of you, so we're going to be talking about the work that we're doing in Illinois on hypertension. How many of you have taken care of a patient with severe hypertension? Almost everyone. How many of you know at your hospital what's your rate of time to treatment within an hour? Do you know what your percentile is at your hospital? Can you raise your hand if you know? No one. And that is not surprising. And we didn't know either in Illinois when we started this work. And what is really interesting to find out, even though we all in obstetrics think we really know how to take care of preeclampsia and hypertensive disorders of pregnancy, because it's one of the major things we do. It's from nurses and physicians, this is our job. It's something that happens commonly, and we need to know how to do it. But what we realize is that patients reach standard of care for treatment of severe hypertension not appropriately. The data would suggest both in California, Illinois, other places that have actually done this data and collected data at a state level, probably only 40% of the time are women treated within 60 minutes, the standard of care for time to treatment for severe hypertension. So this really calls out for quality improvement. It's something that's common, and it needs to be addressed. So with that, I will get started on my talk. So why do we do this work? So what is it about severe maternal hypertension? How did we decide to tackle this in Illinois? I think we were also really motivated by the rising rates of severe maternal morbidity and mortality. We wanted to work on something that we felt that we could make a change and make a difference. And we wanted very much to drop severe maternal morbidity rates in Illinois. Preeclampsia and maternal hypertension account for about 9-10% of maternal deaths in the United States, leads to lots of fetal problems and preterm birth, and about 1/3 of severe obstetric complications. So really, when you're talking about severe maternal morbidity and something that's preventable, this is a really important area to address at your hospital. Elliot spoke a lot about this morning, and I think that we really owe it to the media for all the attention they have shown on mothers' deaths and severe maternal morbidity in the last year. It's getting a lot of attention. Our state legislators are paying attention. In our state, 20 bills directed at maternal and child health were put into the legislature over the last few weeks. People want to make sure that we're taking care of moms and we're keeping them alive during pregnancy when they come into our hospitals. And there's going to be more and more, I think, legislature coming forward, more folks, more looking at how to regulate what we're doing. And I think it's our job to take the mantle and figure out how to do this work. I think we're going to continue to see articles about women dying in childbirth, but what I really hope that we're going to start seeing is articles about all the amazing work that's being done. Jean's shaking her head, yes. And that's our job. Our job is to make sure that alongside those articles, they're starting to see that there's an incredible amount of work happening, and we should be out there in the front, making sure that each of our institutions are doing this work. So these are some of the faces. Some of those faces will look familiar from pictures that Elliot showed this morning. We start each of our group meetings, we start with patient stories and we end with patient stories. It's really an essential part of what we do. I really motivate and encourage you to use patient stories when you are talking with your hospital and trying to motivate. The one on the top is a really great article that got sent around. I think almost every labor and delivery in Illinois has that article posted. So it's the primary cause of maternal death is hemorrhagic stroke caused by untreated severe hypertension. Elliot brought this up this morning. It's really important people understand this because they talk so much about seizure, and they really do not think that the person in front of them who has that severe high blood pressure is going to die. They do not think that, oh, she's mad, oh, she's in pain, oh, she's in labor, and she has a severe hypertension. They really don't think that she's going to stroke in front of them and die. And that is the number one way that women die from high blood pressure. They say she doesn't have a preeclampsia diagnosis, it's just high blood pressure. She's not going to die, and they do. National guidelines recommend timely treatment of severe hypertension in less than 60 minutes to reduce maternal stroke and severe morbidity. We know this is endorsed by ACOG and the AIM maternal bundle. That's a really important message, that as much as we know about preeclampsia, I can't tell you how many labor and deliveries and hospitals that I've spoken at who did not understand that issue. So we took this challenge to really reduce the rate of severe morbidity in women with preeclampsia, eclampsia, by 20%. And we set out to do 4 things. And this is, I guess, where the collaborative, we try to be very specific. So rather than the entire hypertension bundle can be kind of a guidebook, right? But what we want to do is take that, like Jean said this morning, it's like eating an elephant. And we want to be really specific about what we're asking our teams to do. And we focus them, and one of the ways we focus them is with data. So reduce time to treatment, improve postpartum patient education, improve postpartum patient follow-up, and improve provider and RN debrief. And that's having a conversation between the physician and the nurse at the time of treatment that says, how did we do on time to treatment? It's like pulling the veil away from a second when you're right in the middle of treating that patient and pushing the IV labetalol, where you look at each other and say, how did we do on time to treatment? It's just taking that quality moment and then jotting down what went wrong or what went right. We had 110 hospitals who kicked off with us in May of 2016. And then we had 106 of those hospitals submitted monthly data. So we had a few hospitals that didn't end up doing, just 4, I think, didn't do data. And we ended up having over 17,000 women in our data set who had severe hypertension. And so those are all our hospitals submitting every woman who had severe hypertension in the state of Illinois over the course of the initiative. We moved into sustainability mode in January 2018. Typically, we do initiatives for 2 years of active phase initiative. We're actively moving on our key goals to achieve very specific benchmarks, and then we move into sustainability. During sustainability, we really pushed, we call it crossing the finish line and sustaining the gains. So any team who's already reached their goals, we work on sustaining the gains and putting sustainability plans in place. Any team who hasn't reached the state goal, we put all of our efforts into getting them across the finish line. We had, and then after we finished, we have 86 teams. Basically, when we stopped, we said, okay, we're stopping the active phase initiative. They said, oh no, you can't take the data away from us. We're going to continue to submit monthly data and use this as our data tracking system. So 86 of the 106 hospitals have continued to use our, the ILPQC data system as their sustainability plan. I'm just going to show you some things and go through them quickly because I want to make sure we have time for questions. This is our key driver diagram. So you can see in the middle key drivers, we use the bundle elements and put in interventions that can be done. But then we really tried to focus our teams and not to be overwhelmed by all the different interventions, really stay focused on our 4 key goals. So we said by December 2017, we were going to increase the portion of women treated for severe hypertension in under 60 minutes. And we actually said as soon as possible, and most of our teams actually achieved in under 30 minutes. Increase the proportion of women receiving preeclampsia education at discharge by over 80%. Increase the proportion of women with follow-up appointments scheduled within 10 days of discharge by 80%. Increase the proportion of cases with provider-nurse debrief, so where a provider and nurse actually talk to each other and said, how did we do on time to treatment? To where 50% of cases were debriefed, and then reduce the rate of severe maternal morbidity by 20%. That seemed really daunting to us when we started. We were like, how could we possibly reduce the rate of severe maternal morbidity by 20%? And we just said, we got to put it, that's what we want to do, so we're going to put it down and we're going to push everyone. And this is what we challenged our teams to do. And when we started, we were nowhere near. I mean, nowhere near. Our debriefs were at 2%. Time to treatment was at 40%. It was stark, and we were like, this is a lot of work to do, and our teams were up for the challenge. So how did we improve care? Early recognition of hypertension and correct diagnosis during and after pregnancy, reduce time to treatment. I couldn't say that enough. That is the #1 thing that we need to do. You cannot walk into a labor and delivery in Illinois right now or into a prenatal office, and if someone tells you that there's a blood pressure of 165 or a blood pressure of 110 on a patient, everybody's head swivels. It's like you just announced that someone had a heart attack. Everyone sees that as an urgent emergency. It is an emergency, and everyone goes into action. People are calling ambulances. People know that women can die when they hit that blood pressure. It's considered an emergency just as if someone had an MI in your office. And that is just the culture across Illinois, but that happened through this work. We provide patient education and appropriately timed follow-up. Again, we are very concerned about these patients in the postpartum period. A lot of work goes into making sure that they're appropriately followed up. No patient just comes through the hospital, has a severe range blood pressure, and wanders on out back into the community. They're really tracked and followed. Implementation of evidence-based protocols and management of severe hypertension. So getting those protocols. This is a slide that I stole from Elliot, but it used to say control the damn blood pressure on it, but I just didn't feel comfortable with that. It's my growing up in Iowa, I guess. So controlling blood pressure is the optimal intervention to prevent deaths due to stroke. So it just has to happen. Severe hypertension is an emergency, and we have to change culture on that. This is what we call it our Ghostbuster sign. I don't know if they started calling it that. This sign is plastered all over the state of Illinois, basically. You can't walk into like a nurse's bathroom without seeing it on the back of a door, or a labor and delivery. And this is just to get people's attention. This is to get people's attention. This is about culture change, posting things where people can see it, and reminding them that this has to happen. There's not an option. If you have a blood pressure with a severe hypertension, it is an emergency, and we all have to act. So it was our quality improvement focus. Provider and staff worked on standardizing blood pressure measurement. Knowing how to take a blood pressure appropriately actually took a lot of our time, making sure people trusted that blood pressure, and then making sure people couldn't say, she had a fight with her boyfriend. She's in pain. We got through to everyone, it doesn't matter how I don't care if she's standing on her head and just did 10 cartwheels, she has a severe range blood pressure which can kill her. I don't care how, her capillaries in her brain don't care how that blood pressure got there. You have to treat it and bring it down. And that's a really important message that we hammered home. Rapid access to medications. Medications were not where women were. You can't be moving women around the hospital from place to place when they have a severe range blood pressure. You have to treat them where they are. IV treatment, making sure that people were not trying to use PO regimens unless it's one of the nifedipine immediate release. Standardize your treatment algorithms. Almost every hospital put order sets in so that they could activate them immediately without having to have someone come to bedside. Provider nurse debrief and time to treatment, the early postpartum follow-up, and then the standardized education. Let me go a little bit faster. So we facilitated collaborative learning, like I talked about this morning. During the initiative, we did 4 in-person meetings, we did 21 monthly webinars, and we did 15 QI topic calls. QI topic calls are small group discussions where you get maybe like 20 hospitals on a call, one team leads. I'm not even on the calls, so they're tired of hearing me talk for sure. So they just get a team leader who leads the discussion in other hospitals, and they just spend an hour talking to each other. The topic calls, the teams choose what they want to have topic calls on, and we get them set up. Rapid response data system was probably the most important thing that made a difference for us to be able to do this work. We could not have done this work unless we could show hospitals what their time to treatment data was and whether they could track it every single month. That really drove them and their ability to do quality improvement. QI support through a toolkit. We went to network meetings and we did a lot of QI coaching calls, particularly with hospital teams who weren't reaching goal. And then we did regular communication. During this initiative, we did a twice monthly newsletter and we did our website with resources. The teams, each team attended the twice yearly in-person meeting. They said they had to participate in the webinar. They collected and submitted monthly QI data. And then during this initiative, we did quarterly structure measures, which we used through AIM. We found that our teams actually wanted to do monthly. The quarterly, people tended not even to bother with them. They didn't submit them as well. They didn't look at them on a monthly basis. So we moved now with our initiatives now, we do our structure measures as well monthly. And it seems to be utilized more readily by our teams. We also required each team has to do a monthly QI team meeting to review their data and develop QI strategies based on their data and set up their PDSA cycle in a 30, 60, 90-day plan. This is the severe hypertension treatment algorithm. This is from CMQCC, and this is really what we were getting teams to activate whenever they had a patient with severe hypertension. The data collection shows all first cases of severe maternal hypertension during pregnancy from 6 weeks, during pregnancy up to 6 weeks postpartum. It is not about preeclampsia. We really work hard on having people forget about whether someone's been diagnosed with preeclampsia or not. This is about diagnosis of if someone has high blood pressure. and the preeclampsia diagnosis is inconsequential to this work. So we did baseline. All of our teams collected 3 months of data, October, November, December, before we started the initiative to find out what their baseline was. We launched in May, and then they started collecting in June of May of 2016, and we collected through December 2017. So this was our data collection. We did severe maternal morbidity by chart review, the CDC definition, time to treatment, patient discharge education, patient follow-up within 10 days, and whether a debrief was completed. For balancing, we looked at mom, if she had a hypotensive episode, and whether there was a fetal heart rate category change, just to make sure for people who are saying, I don't want to treat these moms because I'm worried about the effect of treating a mom with severe hypertension. I can tell you that we found 0 was an issue. We really did not see any problem with treatment of all these 17,000 women developing hypotension or fetal heart rate abnormalities. The structures put in their protocols. They did provider and nurse education on these hypertension protocols. They made sure they had rapid access to IV medications. They did a system plan for escalation of care, particularly for those that needed to transfer up and out to another institution. And then facility-wide protocols for patient education. The other escalation of care was if you had a provider who said, no, I'm not going to treat, and you had a severe hypertension, you need a local escalation of care. You need to be able to go above that physician. So if your physician says, no, I don't need to activate the IV treatment category because she's uncomfortable or I don't believe in that, then you have to have an escalation policy to go above that physician. And almost every one of our facilities put this in place. This is what our data system looks like. Collect into the data form, enter it into the data system, and then you immediately get back this rapid response data. This is bigger so you could see it. That's the data form. We used a one-page data form. Some of our teams used it electronically, some used it at the bedside. This is how you enter it into REDCap, and then this is an example. The blue would be all the hospitals in the state, and the green would be an example of an individual hospital. So here's some of our structure measures. This was getting standard policies and protocols in across units, and again, this is by quarter. So you can see we started out low, and this is triage ED, antepartum, postpartum in red, and labor and delivery in blue. We really pulled the triage and labor and ER into this. It was essential. A lot of the morbidity was happening in the ER. Provider and nurse education, again, very low to very high. And then this is the grand star of all the slides. So this is the big wow fireworks moment. So you can see that we started at 40% time to treatment, all the way over on the right and at our baseline. And then we're now, actually, this is November of 2018. We hit in October of 2017 our goal of above 80%, and we've maintained sustainability through the last year of our sustainability phase. So we were able to not just implement time to treatment, but able to support our teams making the change and sticking with it. And this is what data collection really does for hospitals. The red is missed opportunities, meaning they had a severe high blood pressure, but they went right by it, didn't treat. The orange is greater than 60 minutes. Light green is 60, and the dark green is the 30 to 60. I'm just going to zoom through this because I think we're running out of time, correct? Okay. This is our patient education data. You can see we started out really bad. We didn't send patients home with preeclampsia education postpartum. The dark green is if a hospital is at its goal. So you can see teams already started reaching goal like really early, and then by the end we have almost every hospital in the state at goal, and we've been sustaining at above 90% of women going home with preeclampsia education discharge postpartum. Here's our patient follow-up. This is getting patients to come back within 10 days for a blood pressure check. Again, we started out bad, we got really good, and we sustained it. This is our time to treatment debrief. So it started out with no one doing any debriefs, and we met our goal of above 50%. And that's really hard, but it really changes culture when your nurse and physician turn to each other while you're pushing the fluid and saying, how did we do on time to treatment? Just that term, time to treatment, getting it into the vocabulary seemed to really change behavior. And this is also the really, really important slide. So this is severe maternal morbidity diagnoses. These are all things we pulled out by chart review, all things that no one would want to have if you were having a baby in that right upper hand corner. And so this is what happened across the initiative. We went from 15% down to the first quarter of the baseline to down to 9% our last quarter, which was a 40% reduction in severe maternal morbidity for women with a hypertension diagnosis. And then just recently in the last month, we received the hospital discharge data for the entire state of Illinois across that same time period. Before this, all severe maternal morbidity data had been going up across the state, and we dropped from 10% down to 5%, which was a 50% reduction in severe maternal morbidity based on hospital discharge data for women with a hypertension diagnosis. So I'm going to skip through some of this. This is just the hypertension sustainability, what we did. I'll talk about that a little bit more tonight, but basically we asked every hospital in the state to submit a hypertension sustainability plan. It was really important to making sure that you don't do the work and then walk away from it and then it all goes away. It's pointless to do this work if you can't sustain it. So this was very specific. Every team put in a compliance tracking. They continued to collect data on all patients with severe hypertension, and they tracked time to treatment, magnesium provided, the follow-up, and the education. Ongoing education for all providers and nurses. All of our teams in the state do severe hypertension simulations or drills at least once a year as part of their ongoing education plan. And all teams now have an education plan for new hires. And I would say, Jean, that almost all of our teams use the hypertension e-modules from AIM as their new hire education. Okay, I'm going to talk about this tonight, so I'm going to leave that. That's just what teams thought was most important, and these are our goals for 2018. So even though we're done with the initiative, our teams still want to continue to get together and talk about hypertension initiative. So about twice a year, we're going to have hypertension calls this year, and we'll continue to track their data and to continue to give them feedback. We're really excited about the success of this work and the impact that it's had on women with hypertension in Illinois. And we're also really excited about helping other states replicate this work through their collaboratives. So these are how you can reach us. info@ilpqc.org is our email. And our website has all of our toolkits and everything on it. So thanks, guys.
Thank you so much again, Dr. Borders. And I just want to make sure Dr. Ramsey's slides are being loaded.
Sorry, I ran over. It's really hard to tell that story.
So Dr. Ramsey is going to talk to us about cardiac bundles. Dr. Patrick Ramsey is a professor in the Department of Obstetrics and Gynecology and the Division of Maternal Fetal Medicine at the University of Texas Health Sciences Center at San Antonio. He also serves as the director of the Maternal Fetal Medicine Fellowship there, as well as the Maternal Transport Outreach Director. He is the present chair for ACOG District 11, Section 5, and he currently serves on the Texas Perinatal Advisory. He's trying to cut me off, but I'm trying to keep bragging about him. He currently serves on the Texas Perinatal Advisory Council and Texas Maternal Morbidity and Mortality Task Force. He's our executive committee for the TCHMB. He was one of our co-chairs, and now he has recently been elected as the vice chair of the collaborative. So I will now welcome Dr. Ramsey to the microphone.
Well, so we're going to switch gears a little bit and talk about cardiovascular disease and maternal mortality and some early work from California related to some quality improvement initiatives, which are really compelling and some interesting data. So if we look at the state of Texas, based on the task force report from 2012, cardiovascular events ranked among the highest risk for maternal mortality in the state of Texas. And we've seen that in other states as well, including California, and including the recent version of our report from the task force. And over the past several decades, we've made some improvements in some of the causes for maternal mortality. Hemorrhage, we've seen some decreases. The great work by Dr. Borders is seeing some decreases with hypertensive disorders. But for some of the cardiovascular-related events, hypertensive disorders up until 2005 was flat, but cardiomyopathy rates are climbing, cerebrovascular events rates are climbing, cardiovascular conditions as a cause of death is climbing as well. So there's definitely some pause for concern that we're maybe missing some opportunities related to cardiovascular disease. So the California Maternal Quality Care Collaborative looked at this in a deep dive, and I'll share some of their data from their work, which is really, really interesting. So they went from 2002 to 2006 and looked at all the maternal deaths in their state, and they took those deaths that were pregnancy-related and then specifically looked at which of those deaths were cardiovascular-related pregnancy deaths. And they identified 64 cases, and of those, 42 were related to cardiomyopathy and 22 were related to other cardiovascular events. And I'll break those down for you in just a minute. So it was the leading cause in California over that time epoch from 2002 to 2006. 25% of the pregnancy-related deaths were related to cardiovascular disease, and that was the highest cause of all causes evaluated. And similar to what you see with most obstetric or perinatal or neonatal outcomes, events are higher or disparate among different ethnic groups. And for cardiovascular disease, the rate was double in African Americans compared to Caucasians. So we see the same theme emerging for different obstetric outcomes, that they're higher in African American women. So of the deaths they identified that were related to cardiomyopathy, of those 64, 42 were related to cardiomyopathy, and of those, 29 or 69% were related to dilated cardiomyopathy, and 24% were related to hypertrophic cardiomyopathy, hypertrophic heart disease. And if you break that down for the dilated cardiomyopathy, most of those are peripartum cardiomyopathy cases presenting in the latter half of pregnancy or during the postpartum period, and then followed by a range of other types of cardiomyopathy that were not peripartum related. For those related to hypertrophic heart disease in the cardiomyopathy group, it's kind of a mix of everything. Some were primary, some were related to hypertension, some were related to drug use or valvular heart disease. And then if we look at the other group of patients who did not have cardiomyopathy that had passed away, 22 patients were identified, and it was really a mix of different outcomes: pulmonary hypertension, aortic dissection, sudden onset of death, which was thought to be potentially an arrhythmia, non-valvular congenital abnormalities, coronary artery disease, or valvular disease. So what they really did was cool in this work is they went back and looked at what were the things that were presenting early on in these women, and could we have picked them up earlier by using some kind of systematic approach. And really, there were 64 women that had passed away from cardiovascular disease that was related to pregnancy, and only 2 of those women, or 3%, had pre-existing cardiovascular disease. So typically, our knee-jerk response might be, well, maybe we dismissed these patients, we didn't get them in early enough for care because they had valvular heart disease. But these women were women that did not have known cardiovascular disease. And they came in and they presented sometime during their pregnancy or postpartum period with warning signs that we'll talk about, and weren't recognized early enough. Some of these signs and symptoms were shortness of breath, wheezing, palpitations, edema, chest pain, dizziness, extreme fatigue. Sounds familiar, pregnancy, right? So how do you separate that from what's real concerning? And they've done a great job in California to sort that out. The other really appalling thing from this data is that almost 50% of these women presented with signs and symptoms that were suggestive of something going on related to the heart, either in the prenatal period or during labor and delivery, and it wasn't recognized until after delivery or time they passed away. And 80% of women had symptoms in the postpartum period. The most common findings they noted in their review was hypertension greater than 140/90 in 64% of the cases, heart rate greater than 120, 59% of the patients, crackles in the lung or a gallop or S3 on auscultation of the heart or lungs, 44%, and oxygen saturation less than 90%, 39% of patients. So pretty scary. The oxygen saturation is certainly a scary number there. This slide looks at the timing of the diagnosis. So I already mentioned that almost 50% of these women presented with signs and symptoms that were indicative of maybe something cardiovascular prior to labor and delivery or during labor and delivery. But in this slide, the dark orange in the middle, that 34% is during the prenatal period, the postpartum period. So only about 11% or about 15% of these women were identified before labor and delivery, even though they had symptoms present. So I think that represents a potential opportunity to identify these women and potentially get them in earlier for evaluation and care. They identified that 30% of all cardiovascular deaths occurred after 42 days following birth, and most of it was driven by cardiomyopathy, as mentioned. So they looked at what were some contributing factors. From the healthcare provider standpoint, as Dr. Eppes mentioned earlier, delayed or inadequate response to warning signs. Again, another plug for early warning signs or maternal early warning signs. 61% of patients. Ineffective or inappropriate treatment, kind of falling back to Dr. Border's discussion about management of hypertension, 39%. Misdiagnosis, 37%. And failure to refer or consult, 30%. So there are definitely some opportunities there based on some of these signs and symptoms presenting, getting those patients in earlier, identifying them earlier to have an impact. There were patient-related factors as well, and those were patients had underlying medical conditions, 64% of patients, obesity, 31%, delay in seeking care, 31%, lack of recognition of cardiovascular symptoms, 22%, and some of the opportunities there for educating our patients, empowering our patients to come in to us if they have a concern, express their concerns to us so we can evaluate them thoroughly rather than just a quick phone blow-off that's normal signs and symptoms of pregnancy. And in their work, they identified that probably 24% of all cardiovascular-related pregnancy deaths were potentially preventable. So it does have an opportunity for us to have an impact in this work, in this area. So from that, they developed a toolkit that they've implemented in California, and I'll just share that briefly with you. And they identified a number of red flags that should prompt an immediate evaluation for patients with MFM cardiologists. And those are shortness of breath at rest, severe orthopnea with 4 or more pillows, resting heart rate equal to or above 120 beats per minute, systolic blood pressure greater than 160 or equal to 160, resting respiratory rate greater than or equal to 30, and oxygen saturation less than 34 with or without a personal history of cardiovascular disease. And many of these are the same maternal early warning signs we talked about before. So another way we can integrate some of this care across the spectrum to improve outcomes. And then obviously if a patient has a history of cardiovascular disease, they should have evaluation in the pregnancy at baseline. And they created a very elaborate algorithm based on symptoms, which are symptoms that fit into the New York Heart Classification 2 group, abnormal vital signs, risk factors, and physical exam. And if you had one symptom, one vital sign, and a risk factor, or any 4 of those things in any of those categories, that should prompt an immediate evaluation for evidence of cardiovascular disease. And they took this algorithm, they went back and applied it to their data set, and they noted that they'd identify, if they used this algorithm in the data set, they would have identified 88% of the cases of maternal mortality before they had happened. So that's a pretty striking number. They've also taken this to the next step now. They're applying this toolkit to different hospitals in California and seeing similar detection rates of getting patients in earlier. And we're actually starting to work on getting that into our clinic system in San Antonio right now. I'll be glad to answer any questions during the question and answer session.
All right, thank you very much to all of our speakers. We still have about 10 minutes left now for questions and answers if anyone has any questions.
Dr. Borders, you've done some phenomenal work, and I applaud you for that. The results, though, by decreasing the morbidity and mortality by 50%, it can't all have come from just that intervention. So what do you think is the bystander effect, if you will, of decreasing, for example, DIC or some component of that to your program?
Yeah, it'll be interesting to dig deeper into the data of the severe maternal morbidity elements. I think that we just saw abrupt change in how women with severe hypertension are taken care of. I think that the intervention, when you treat severe hypertension quickly and efficiently, you bring it down, women just don't get as sick. And that is, we just saw this change. They were better watched, they were better informed. The amount of energy that was spent really focusing about process flow. So what you're seeing here is you see reducing time to treatment, early follow-up, right? But what you're not seeing is the process flows that people worked on, engaging patients on their QI teams to think about how do we engage with patients, what's the best education to give patients about this, how do we follow up with them, how do we get them to come back to this postpartum visit. There was such a heightened culture change and awareness of high blood pressure, not just preeclampsia. So we really shifted the diagnosis away from, oh, let's wait, until this person has another 6 hours of a second high blood pressure, or let's wait until we have a 24-hour urine collection of something and get preeclampsia. We really moved to thinking about a woman with a severe range high blood pressure is in danger, and we need to circle the wagons and treat her really quickly, and watch her much more closely, follow up with her in that early postpartum period. So I think that it changed the awareness of how we think about hypertensive disorders in pregnancy in general and how we interact with these moms. And so when you look at an entire state having 50% drop in severe maternal morbidity for women with a hypertensive diagnosis over this 2 years, we just changed the way we approach women with severe hypertension. We moved to trying using the California model of using magnesium with patients not for severe hypertension, regardless if they had a preeclampsia diagnosis. I need another summer intern to dig deep into the severe maternal morbidity data, see exactly how we can find what elements changed, because we haven't done that yet. But I think that when you implement an initiative, we really changed the spotlight, and I think that made a difference for these moms. The time to treatment was a really big deal. Like I said, it's just putting the systems changes in place and the culture changes. You can't do one without the other. So you can put the order sets in the computer, you can write a protocol, but unless everyone who interacts with that mom, from the ER to the ICU to labor and delivery triage to postpartum and antepartum, the person who's taking a blood pressure, they all need to know that a severe range blood pressure is an emergency, and that really changes the way people interact with these moms, and I think that's what made the difference.
And if I can follow up that question with, were you able to tell any differences in successes of the various hospitals based off of the type of hospital it was? Did it vary?
So thanks for that. So one thing that was really important about this work, particularly as we try to think about equity and disparities, when we started out with our baseline data, and we have hospital characteristics based on patient mix, race and ethnicity, insurance mix, so private versus Medicaid insurance, the number of deliveries a hospital does, and urban versus rural. So when we started out, there was a real discrepancy based on hospital characteristics of what hospitals were able to effectively care for these moms. And we definitely saw that our safety net hospitals were less able to hit the time to treatment goals. And so we had a real discrepancy based on hospital characteristics of who was achieving time to treatment and the follow-up. And with the support that we provide through the collaborative and the ability to track data, we were able to really close those gaps in quality. And by the end of the initiative, it didn't matter which hospital you showed up to deliver at in the state of Illinois, you got the same care. And we couldn't, on any of our process or outcome measures, we could not see any difference. There was no significant difference based on any hospital characteristics. And we started out with differences almost on all of the hospital characteristics. And that last analysis showed that really you can change how everybody takes care of patients and improve everyone's quality. You just have to provide a lot of support to teams who have less resources for quality improvement. But the data and being able to watch and see how we were all doing and compare to each other really drove everyone to do rapid improvement. And I think that was really essential. The collaborative learning also was really important. And then the QI coaching that we were able to give to teams who have fewer resources. Sometimes you have one nurse who's has all of the quality improvement responsibilities for all these different initiatives coming down on her head. No one's helping her. And so we're able to step in and say, okay, let's look what you have. What are the resources available to you? How can we leverage what you have? How can we get a provider to come alongside of you? Let's think about a small PDSA cycle. Can we come out and do a grand rounds for you? So that was really essential. Another thing we did was we had grand round speakers series. So we got OB providers from around the state who'd be willing to give our grand rounds. And then they signed up to be in our speakers bureau. So it was, again, giving people jobs. And they went out and did grand rounds at the different hospitals and tried to also bridge the gaps where these providers who get really stubborn and say, I'm not going to change. I don't need to use the ACOG IV treatment. And we would use those providers in our speaker bureau to kind of really get people to see that they could change and they didn't have to be so stubborn.
Thank you. And I can keep going with questions unless, okay, thank you, 5-minute warning. Dr. Ramsey, if you can talk a little bit about, as you're looking to implement the cardiac bundle in your hospital, what challenges or barriers are you coming across and how are you overcoming them?
Great question. So we've been meeting with we're trying to implement this in our clinic system so we can identify these women before delivery. And I think the biggest barrier has been trying to get it integrated into EMR. It's not, takes a long time to get those systems in place in the EMR, and it's not deemed as a high priority right now. So just trying to present the evidence that it's important to do this and that we can get these patients in and refer out to the cardiology practices has been really important. But we're at early stages of it right now.
And Dr. Eppes, as I mentioned, Dr. Eppes implemented the maternal early warning system at Taub. I think you said 2017, but it was actually 15, yeah. So it was even longer ago. And then she went from there to implement OB hemorrhage and hypertension. So this is a little bit of a obviously planted question because we co-chaired the OB subcommittee together. But if you can kind of tell or describe why we have selected Muse as our QI initiative within the collaborative and how you think that plays into these other bundles.
First, I just want to expand and correct on what you say. I didn't implement it in our hospital. We implemented it in our hospital, and there are so many Taub people here today, so I want to make sure to highlight all of the hard work that they did. I just get to be the person that talks about it.
You did lead the efforts.
So your question was, why did we pick doing that first? Well, within our hospital, it was based on our outcomes. So I think one of the, if you're looking at chronologically, the 4 R's, systems-based learning is the last one. But I think for us, it came from that. So we had a long process of case review going on at our hospital and found a consistent pattern of delayed recognition. And knew we were having severe morbidity in our own hospital because of it. So it seemed obvious that that's a place that we needed to start. We knew also postpartum hemorrhage was a problem, but this seemed to be something that could be tackled. Why we think it's important as the collaborative for the state, it's sort of it's an essential component to all of them, and I think being able to pull out this piece to really help hospitals, a lot of the things that Anne was just saying about being able to touch hospitals and give them the QI that they need, I think carving it out as a smaller piece within the huge bundle, Muse allows us to do that. So, for example, I'm going to embarrass you, Amanda is sitting right here in the front, and she's the QI nurse who would come out to hospitals to help and to do that touch point if they need it for that ongoing assistance. And I think this just gave us a very tangible way to help people going forward. I also am biased and think it's kind of the most critical part of the whole process, just from my own experience.
Yes.
I had a question. Great presentation to everyone. Thank you. It's a question for Dr. Borders. If you guys had any streamlined process or keywords for when the OB provider sees the severe range blood pressure in the clinic, anything to call the hospital or to go through ER triage that would initiate treatment faster?
Yeah, so that was really interesting. We've had a ton of conversations about that, even in my own MFM office. All of our nurses, they get someone with severe range blood pressures, and it's like, how do we get them in? So we chose very specifically during the initiative to focus on inpatient, and it's, I think we were an early starting out collaborative, and I think we're now moving towards, like, for example, our opioid initiative. We're working both inpatient and outpatient, and we have outpatient champions on all of our QI teams. But we had a lot of hospitals who chose to invite an outpatient champion to be on their hypertension team just for that specific issue. How do we make sure that patients that a lot of the morbidity for preeclampsia and hypertensive disorders pregnancy starts in the outpatient settings with people's failure to identify women whose blood pressure is starting to go up or effectively respond to someone who has severe hypertension even. So some of the strategies that people have used, I've seen some people who have the immediate release nifedipine available that they can give a patient. For most of the cases, it's having a protocol in place that when you have a blood pressure that's sustained, so we defined severe hypertension as sustained for greater than 15 minutes, greater than equal to 15 minutes, so repeat it in 15 minutes. So if you have a severe range blood pressure that's repeated in 15 minutes, still sustained, then we see that as an urgent referral to get that patient onto labor and delivery. So typically we move that patient as quickly as we can to labor and delivery and try to get them treated as quickly as we can. If their blood pressure medication is with them, we tend to give it to them while they're there. But for the most part, it's having a communication line open with the labor and delivery so that everyone sees it as an urgent transport, and that you got to get that person treated as quickly as possible. It's hard with places that are remote from their labor and delivery, and that's why in some places I think they started stocking. But then they wanted to be able to watch the patient and monitor their blood pressure after they gave the nifedipine. So there's like a whole nother, that's in a whole nother kettle of fish. So I think it's important to start small and really focus on making the improvements you can, but that outpatient setting is really critical. And I think we had a lot of hospitals who did engage outpatient champions and tried to work through some of those issues of making sure that women were being appropriately referred to labor and delivery and appropriately evaluated when they had signs and symptoms of high blood pressure in pregnancy.
And our time is up. I have one quick question for Dr. Borders, just to clarify the time to treatment in 60 minutes. I'm just curious, for the sustained hypertension, is the within 60 minutes from the first blood pressure or the second one 15 minutes later?
We would start from when the patient had severe high blood pressure.
Okay.
And then move. And our goal was to really get that patient treated as quickly as possible.
Thank you.
The first
The
blood
first.
pressure. So
The
it's like
first
how long has that person had sustained high blood pressure? And we had hospitals that really moved towards really trying to move really quickly to be able to treat. I mean, you could see that almost all of our hospitals by the end of the initiative can treat in under 30 minutes. And that's just because they had the systems in place and everyone saw it as an urgent emergency. So for the most part, most of our hospitals could treat within 30 minutes. And that's the same experience that they had in California. Most hospitals, because we had a lot of those hospitals. On our monthly calls, we have nurse or a physician leader from other states get on our calls and share, because they're always ahead of us, and so it always inspires our teams. And they were almost all treating within 30 minutes. We just used as our benchmark 60 minutes because we wanted to help us succeed.
Thank you very much.